have people, and I'll formally introduce you. So we'll get
Sure.
started.
Sure.
So, hello everyone. I warmly welcome you all on the IASNM MSc webinar series. This webinar talk is going to be around 30 to 40 minutes, followed by 10 to 15 minutes of Q&A session. Just a few housekeeping things to keep in mind. Keep your phones and devices on the mute during the talk. And if you have any questions, please, we'll answer the questions at the end of the session. And you can also type in your questions in the chat box. Now, it's my absolute pleasure to introduce Dr. Parag Aland for this webinar series. Dr. Parag Aland is Head of Nuclear Medicine and Therapeutics at Saifee Hospital, Mumbai, and his past affiliations include Jess Lake Hospital and Research Center, Mumbai, and Breach Candy Hospital, Mumbai. Dr. Paragalan got his training at Radiation Medicine Center, Mumbai, and Jaslok Hospital and Research Center, Mumbai. He also did his nuclear medicine therapy fellowship at Frontier Hospital, Australia in 2010, and he was a visiting researcher at University Hospital, Pennsylvania in 2009. His key interests include neuroimaging and radionuclide therapies. Now, Dr. Parag.
Thank you so much for the kind introduction. Always pleasure talking to a vibrant audience, and I thank you for giving me this opportunity. I will start sharing my screen for the slides. Okay, so the next few minutes, about 35 minutes odd, I would be focusing on presenting my experience with dementia and movement disorders. I wouldn't be as much focusing on the theory or the literature part of it because a lot of literature is easily available on web. I thought I should focus more on what I have learned from my practice based on my interactions with my colleagues and the neurology clinicians as well. So with this premise, we of course have to know the basic relevant neuroanatomy. We know all the lobes, but of specific interest is the sensory motor cortex, the parietal lobe, specifically the precuneus and posterior cingulate gyrus, the visual cortex and the visual association areas, as well as the temporal lobes. These are the primary areas of interest as far as your neuroimaging is concerned for dementia. The precuneus, a small strip of cerebral cortex just above the posterior cingulate gyrus. The cingulate gyrus itself is a thin strip of tissue above the ventricles and arbitrarily divided into anterior, the mid, and the posterior part. Of particular interest to us is the posterior cingulate gyrus and the precuneus. What brought me interesting to this particular topic is some cases like this. Now, if I'd like you to focus on these two cases, the series 1 of cases here and the series 2 cases, an elderly gentleman presenting with word finding difficulties. You have hypometabolism predominantly in the parieto-temporal areas. Precuneus, of course, looks all right. And in the second scan here, it is a fairly normal metabolism with mild hypometabolism in the visual cortex. Now, what is remarkable here is both these scans belong to the same individual. The difference is in patient preparation. He was a 70-year-old neurologist himself, and he said, "Hey, look, Parag, I have some issues with word findings. I would like to rule out dementia since I see so many patients." And the day one he came for the scan, I gave him a brief set of introduction and instructions, and he sat in his waiting area with his mobile screen on and reading literature on his mobile screen, which I did not notice, and he also completely missed it. And there you see a bright visual cortex causing an artifactual normalization artifact and causing a false hypometabolism in the parieto-temporal regions. I did give him this explanation. He said, "I'll come back for a scan tomorrow." A couple of weeks later, he came back for a second scan. And here, of course, he overcorrected himself by just shutting his eyes closed with no visual stimulus. And that explains the visual cortex hypometabolism. So patient preparation is very critical. That the room should be a dim lit room with no visual stimulus, no kind of stimulations beyond the necessary. Also, on the other end of the spectrum, if the patient is bedridden, somebody should be making a note if the patient is keeping his eyes open or the eyes are shut, because if you see visual hypometabolism with a relevant clinical context, you are then likely to label these patients as Lewy body dementia. And hence, the patient preparation is the first step towards getting a good quality scan report. While processing brain PET images, before even you start reading images, you have to look at these 3 points. One, whether the images are processed in the line that crosses the anterior as well as the posterior commissure. This is important to attain reproducibility of images, comparison between different modalities, because if there is if there is a deviation in these processing protocols, then you are likely to read different scans and you're likely to misread the areas of hypometabolism. The next step is important is the normalization. Whenever you use quantification softwares, the software asks you a question, where do you want to normalize this data compared to the normal database? And depending on what region you normalize, your 3D generated statistical images are going to be vastly different. Here is a literature study which demonstrates rather the age-related atrophic changes across variable or structures in the brain. And here, the least variation with progressive age is with the midbrain predominantly. And hence, unless you're dealing with something like a progressive supranuclear palsy, your 3D images or your quantification softwares should normalize your brain images to the midbrain, because the variability with age in these areas is the least. If you're going to normalize it to something like precuneus or frontal lobes, it may falsely normalize that as normal, and your entire brain scan can look completely normal. These are good softwares. I used them a lot in my earlier years, but of late I do not use them as much. It's more like an adjunct to my scan reading sessions. And this is why I say so. With visual evaluation, uh, the improvement in sensitivity or specificity for an expert who has read a considerable number of scans, the increment is only marginal or probably no increment at all. But somebody who's at an early stage, who's learning with reading neuroimaging, compared to the visual imaging itself, the quantification softwares add a substantial improvement to the scan reading abilities. So yes, these softwares are helpful, but you cannot use these for your primary scan reading. They can be an adjunct to your reading. You have to develop your eyeball to reading scans visually slicing. So to pick what is abnormal in the brain, it's first important to see what is normal. You should be separating the normal variants from the abnormal variants. Few areas in the brain, most notably the basal ganglia, the frontal eye fields, the posterior cingulate gyrus, and the visual cortex, of course. These areas normally show a higher grade metabolism compared to the rest of the brain parenchyma, simply because they are more in use. Some areas, like the medial temporal cortex, will show slightly lower metabolism compared to rest of the brain cortex. These are physiologic variations. There will be slight asymmetry in Wernicke's areas with hypermetabolism more towards the dominant areas, as well as the angular gyrus, as well as frontal eye fields. This is more important when you're reporting epilepsy rather than dementia. However, these points should be factored in before you actually read a scan. Now, I usually use my brain PET images as an internal standard within the brain to pick what is normal and what is abnormal. For example, the posterior cingulate gyrus at the level where you can see the entire posterior cingulate gyrus, this cingulate gyrus is the hottest structure in this particular slice. If the cingulate gyrus is lesser than, say, the frontal lobe here, it is then that you label this as hypometabolism. Likewise, when you go down at the level of visual cortex, the medial occipital cortex should be at least equal to, or ideally should be brighter than this striatum. And if this particular area is hypometabolic, you term it hypometabolic when the intensity of activity in this region is lesser than that of this striatum. This lends some objectivity to the image reading rather than just arbitrarily saying, it looks like a mild hypometabolism or a moderate area of hypometabolism. So you develop internal standards, and using that within the same patient, you can somewhat semi-quantitatively arrive to a point being called as hypometabolism or normal metabolism. In the same thing, I would also continue a bit about, since I'm speaking about image interpretation and quality and preparation, I will also continue the same line for the TODAT imaging, and then I'll come to the clinical aspects of this. So in India, we of course do not have the beta CIT. We have technetium labeled TODAT, and these these guidelines are for technetium TRODAT scans. Optimization of procedure for a TRODAT scan is at most important because the non-specific binding is high and a very small percentage of what you inject actually goes and localizes to the striatum. Hence, the count rates are really poor. And in such cases, you want absolute good quality image acquisition parameters so that you at least get a decent quality scan. Three primary things impact the quality of the scan. One is how much of activity you've injected, how is the uptake time, meaning the time between injection and the scan acquisition, and then the amount of time that you've spent actually acquiring the scan. In this particular study, signal to noise ratio across the striatum were calculated in three groups: level 1, where the injection was lowest; level 2, where the injection dose was medium; level 3, where the injection doses were high. Likewise, for uptake duration, 1, 2, and 3, indicating 2 hours, 3 hours, and 4 hours from the injection time, and likewise for the time per projection. And it was appreciated that, of course, naturally speaking, with higher injection, higher uptake time, and higher time per projection, the scan quality will get better. But what was surprising is the amount of injection provided just marginal increment in the signal to noise ratio, whereas the uptake duration, that is the time from injection to the acquisition time, is the highest, is the best when the waiting time is at least 4 hours from the injection, and likewise for the time per projection. So if you have to choose one of the three, I think the uptake from the injection time is the most important parameter, followed by the time per projection, and the last being injected activity. The ideal doses would be to about 20 to 25 millicuries of TRODAT with time of at least 4 hours from the injection time before you take the patient up for the scan, and you acquire for 60 seconds per frame. Once you've acquired, watch out for these artifacts you are likely to encounter when you're reading a TRODAT scan. If there's a lateral motion, as evidenced by the broken sinogram here, you're likely to see the chordates more approximated to each other, which is informally called as kissing chordate sign. Second is when you're processing, if the patient's head is in slightly tilted position and you tend to process it in the same slice, when you look this in the transaxial, you're likely to see an asymmetry at a few slices, and you may falsely end up labeling these as asymmetric dopaminergic deficit indicating Parkinsonism, whereas essentially this is a normal looking striatum just with a tilt in the processing. And the third important thing is the forward tilt. If the patient is seated, is lying down with a forward tilt, the caudate and the putamen end up being separated, and you will get a semicolon kind of pattern instead of a classical comma-shaped pattern. Which brings me to the question, why do I at all need imaging in cases of idiopathic Parkinson's? The simple answer is no. If the patient has a classic symptom of triad of Parkinson's disease and there is an objective demonstrable response to syndopa, no imaging is necessary for idiopathic Parkinson's disease. The highest utility is in patients who have symptoms similar to Parkinson's, but clinically they're uncertain. Based on the literature published in a neurology journal, Parkinson's is misdiagnosed in as many as 1/4 of the patients. The famous Query PD landmark study, which was again done by a neurology group, demonstrated the clinical sensitivity for diagnosing Parkinson's being as high as 90%, but by their own admission, the specificity is poor at only 30%. That scan, when incorporated in the algorithm of these patients, improved the accuracy of diagnosis. Over half the cases, the diagnosis was changed, and it led to eventual change in clinical management in about 70% of the patients, which by no means is a small number. And this is where you need objective imaging. One more entity I'd like to mention here is scan without evidence of dopaminergic deficits. It was observed in about 11% of the patients. These patients were categorized as a subset of Parkinsonian patients who do not progress, who do not respond to dopaminergic drugs. Now we probably think that this possibly was a non-Parkinsonian syndrome, which was diagnosed as Parkinson's in the pre-imaging era, because essentially, barring functional imaging, there is no other modality that can objectively demonstrate or confirm Parkinson's disease, at least in the early stages. What isotopes or what radiopharmaceuticals are available? There is a whole list of pharmaceuticals available, but I would focus on two areas. One is the DOPA analog, that is the F-DOPA, which is essentially a substrate for DOPA amino acid decarboxylase enzyme. And second is the presynaptic receptors, the DAT receptors, the dopamine transporters that we focus on, and technetium trodat or the beta CIT are the commonest used isotopes here. Yeah, again, the activity of the F-DOPA closely parallels that of the levodopa. And yeah, that's so. And this is why we need F-DOPA compared to a trodat scan. A trodat scan can barely demonstrate the striatum bilaterally, seen as blobs here. And more often than not, you will end up getting images like this, although sometimes, if you're lucky, if the patient is young, if the signal to noise ratio is better, you will get slightly better images. But ordinarily, you will end up get imaging like this, where differentiation of the caudate from the putamen is very difficult. Whereas in F-DOPA images on the right side, you can very well demarcate the caudate and rest of the putamen. Not just rest of the putamen, you can also see a gradient between the anterior putamen and the posterior putamen, which is impossible to differentiate on a trodat scan. This has some diagnostic implications because if you study the intrastriatal gradient of deficit whenever the patient with Parkinson's presents, they have slightly different presentations with atypical Parkinsonian syndromes versus idiopathic Parkinson's disease. I'll come to that a bit later. A classical example of your normal dopamine transporter study, symmetric uptake in bilateral chordates, symmetric uptake in bilateral putamen, and the intensity across the putamen within the putamen is very, very consistent and stable. Compared to this, in the second image, you're seeing the left-sided striatum looks fairly good, whereas the right-sided striatum, you're seeing some tailing off in the region of putamen. You see an asymmetry in the uptake as well as the lengths of the putamen. At the same time, you also see some increased background activity. Just putting it in a different color scale so that the difference between the two is more striking. And in the third case, you see there is deficit in bilateral putamen, chordates fairly preserved. So this is how a normal dopamine transporter study on an F-DOPA PET would look like. Whereas here, an early Parkinson's would look like this, with an advanced Parkinson's eventually showing off different uptake pattern altogether. Here's another sign which I typically see as a bunny. If you see this, it's a MIP image laterally. And this is where you see a striatum on the MIP image in a lateral view. And this part here is the caudate, and this part here is the putamen. And if you compare this normal scan to the abnormal scan, you're barely seeing any putamen here. So the MIP image itself, in addition to the QC, will give you some hints towards diagnosing or identifying Parkinson's disease. Once you see this, the next step would be to ensure that these slices are appropriately aligned. And third step would be then to start looking for asymmetry. This is the visual quantification. Visual assessment, whereas the next step is the quantitative interpretation. Various measures have been tried where you can draw ROIs over the chordates, the putamen, the whole putamen, or the anterior and posterior putamen, and the ratios are taken with the occipital cortex as the reference standards. Some theories say that the differentiation between anterior and posterior putamen is arbitrary because there's no organ or structural difference between the two, and hence instead of taking two gross areas as anterior and putamen and posterior putamen, you can actually take multiple ROIs as a 9-point system and compare ratios across all of these. These, in my opinion, are more of an academic or a theoretical research interest. Practically, I think your visual interpretation is really as good as your quantification. One more point with fluorodopa as an advantage over trodat is you can actually quantify the intrastriatal gradient of uptake in the putamen. The theory being in patients who have an typical idiopathic Parkinson's disease, the drop of the putaminal dopaminergic uptake is linear, which means the anterior putamen as well as the posterior putamen show a linear reduction in dopaminergic uptake, whereas with Parkinson's plus syndromes, anterior putamen usually shows relatively preserved dopaminergic tracer uptake, with posterior putamen being affected earlier, followed by the caudate showing a deficit in that region, and then eventually the anterior putamen also goes down. But again, that's largely theoretical. For all practical purposes, I think the visual interpretation suffices. Another case of a Parkinson's disease, the reason I'm showing you this slide is the chordates show normal tracer uptake, but you're seeing a clear deficit in the putamen. But here, this bright structure that you see here, this is uptake in the pineal gland. And the reason why we are seeing uptake here is because as a compensatory mechanism to the dopaminergic deficit in this striatum, the body tries to increase the dopaminergic activity elsewhere. That's why you're also seeing a little bit more of thalamus than usual and the focal uptake in the putamen. So, sorry, not in the putamen, in the pineal gland. So one theory says that the activity in the pineal gland correlates to the severity of the disease. In this case, she was a 35-year-old doctor, medical practitioner, a physician by profession, presenting with symptoms of Parkinsonism and very rapid progression, and she had severe young onset Parkinson's disease. A classical example of how a Trodat scan would look in an idiopathic Parkinson's disease, a deficit in one putamen, and the contralateral striatum showing a very good preserved structure as well as function. FDG brain PET in cases of idiopathic Parkinson's disease is usually normal. Sometimes you may actually end up seeing a mild hypermetabolism in this striatum because body is trying to compensate the dopaminergic deficit by overactivity. But by and large, most idiopathic Parkinson's disease will have a normal brain PET. Whereas in all the atypical Parkinsonian syndromes, your brain PET is going to be completely abnormal. And that is how you arrive to a diagnosis of Parkinson's, of sub-diagnosis of a Parkinsonian syndrome based on a combination of Trodat or an F2 PET along with an FDG PET scan. Lewy body dementia, of course, is similar to Parkinson's disease with dementia, but the difference is there is near simultaneous onset of motor as well as cognitive dysfunction. Typically, they present within 1 year of each other. Most of them present with motor dysfunction as an onset, with very closely followed by cognitive dysfunction within the next years. Of course, there are major and minor criteria for all of this, of which one of them is an FDG brain PET. Going back to the normal slide for reference, the visual cortex, which normally is brighter than the striatum, in case of a Lewy body dementia, it will show hypometabolism compared to the striatum. Normally, the visual cortex should be the brightest structure in a given slice if it is normal. Also of importance here is something called as a cingulate island sign. While in cases like Alzheimer's, you will see a precuneus or a posterior cingulate gyrus hypometabolism. In cases with dementia, Lewy body dementia, the cingulate gyrus metabolism is well maintained, but the visual association cortex area will show hypometabolism. And hence, you will see a relatively bright spot within areas of hypometabolism, which is fairly specific for a Lewy body dementia, although it may not be always demonstrable. The next Parkinsonian syndrome is the corticobasal degeneration. Patient typically presents with alien limb syndrome, myoclonus kind of features, dystonias, which is typically asymmetric. Patient presents with complaints, in addition to cognitive disability, patient presents with complaints of feeling one of the arms as alien to him. He says, "It's not in my control. I don't know how this feels." In these cases, when you do a Trodat scan, you will see striatum showing hypoactivity or reduced or a dopaminergic deficit in the area contralateral to where you have the clinical presentation. What is peculiar about Parkinsonian syndromes or Parkinson's plus syndromes is unlike an idiopathic Parkinson's disease, where you see a dopaminergic deficit in one putamen that is typically on the contralateral, and as the disease progresses, the ipsilateral putamen goes down, then the contralateral caudate goes down, and then ipsilateral caudate goes down. But with patients like Parkinsonian syndrome with CBD, you will see contralateral putamen going down, and near simultaneously, the caudate also goes down in the same area. And subsequently, as the disease advances, the ipsilateral caudate as well as the putamen then start showing hypometabolism. Just for an example, with an idiopathic Parkinson's disease, unilateral deficit in one putamen with the rest of it being normal, but with a CBD, unilateral caudate as well as putamen showing a deficit. Also, if you notice here, the anterior putamen is relatively well maintained in this case, as probably if I had done a fluorodopa in this patient, I would have demonstrated this in a better way. Brain PET typically will show asymmetric area of hypometabolism, typically involving the cerebral cortical ribbon, but it also shows similar hypometabolisms in the striatum and the subcortical structures contralateral to the side of clinical presentation. So the hallmark of this is asymmetric hypometabolism. Multisystem atrophy, depending on the site depending on what area is involved, either the MSA-C type, which is primarily presenting as ataxia, versus the MSA-P type, which primarily presents with Parkinsonian syndromes, your scans are going to look abnormal accordingly. With an MSA-P type, you're going to see prominent hypometabolism in the striatum in addition to parietotemporal lobes, whereas with the MSA type C, very severe hypometabolism is demonstrable objectively in the cerebellar hemispheres. Progressive supranuclear palsy is an interesting group. There are very many subtypes depending on the area involvement. Commonest being, of course, the brainstem involved or the midbrain involvement, which present with a vertical gaze palsy. But there are numerous others which are frontal predominant, which are behavioral predominant, FTD variant of PSP, and so on and so forth. But for academic purposes, I'm restricting myself to the classical vertical supranuclear gaze palsy patients. These patients have predominant affection in the brainstem and midbrain. Patients have features of dementia, but in addition to that, the features of Parkinsonian syndromes are present. And striking feature amongst this, because of the pseudobulbar palsy, is the impaired ocular motility. Patient typically has difficulty in moving eyes up to down, vertical gaze palsy, and hence these patients frequently present as frequent falls along with movement disorders. Clinically, they should be differentiated from falls because of ataxia. Here, the patient will typically demonstrate and complain about visual disturbances in addition to the Parkinsonian syndromes. Dementia also presents, but it is relatively mild at the outset. The dominant symptom here is the motor disorder. Parkinson's TRODAT will be obviously abnormal. Here you're seeing a homogeneous reduction in bilateral striatum with excessively increased background activity. And with FTG brain PET, you will see areas of hypometabolism in the prefrontal cortex, the parietotemporal lobes, but the most important or pathognomonic hallmark is the hypometabolism in the midbrain. Going back to anatomy a bit, the upper brain stem predominantly involving midbrain and pons normally show bright areas of metabolism, whereas in cases of PSP, you will see that these areas will show reduced metabolism, most prominently the midbrain, followed by the pons. Here is another slide for your comparison. A normal scan showing midbrain and pons metabolism, whereas a PSP patient, in addition to prefrontal cortex hypometabolism, classically demonstrates pons and the midbrain hypometabolism. If you go back to the first few slides that I had mentioned, this cannot be an age-related thing because the variability of midbrain activity or atrophy for that matter is the least with progressive age. And hence, as age progresses, like you may see parietal atrophy and consequently demonstrating atrophy on your parietal lobes, which again subsequently demonstrates hypometabolism in those areas. This is not the case with midbrain. If your midbrain is showing hypometabolism, it's most likely pathologic. The last group is frontotemporal dementia before we move on to Alzheimer's. This is typically a young age onset dementia. Alzheimer's classically presents after 65, whereas FTDs are very frequently seen in the age of early 50s. Depending on the dominant of area involvement, it will be either behavioral or a long language predominant cognitive decline. Behavior patients present with behavioral FTD present with a lot of rapid change in behaviors. A person who's aggressive may suddenly become indrawn. A person who is calm and composed may become violent, and so on and so forth. The classical presentation, as the name demonstrates, is a frontotemporal lobar degeneration, dominant areas of hypometabolism involving the frontal and the parietotemporal lobes, mainly the temporal, not as much the parietal, with the precuneus or the posterior cingulate showing a preserved activity. Vascular is typically caused by ischemic lesions. These can be differentiated between microangiopathy or simply a large vessel stroke, as in this case, almost the entire left cerebral cortex is gone. But if it was to do with the microvessel or microangiopathy, you are likely to see areas of hypometabolism scattered around the gray zone and white zone transition, gray matter and white matter transition, because this is typically where the angiopathy is known to exist maximally. And hence, these are random, scattered, patchy areas of hypometabolism with no specific pathognomonic feature. Alzheimer's, of course, is the most common dementia type. We have the FTG PET and we have amyloid imaging. But in India, of course, I don't do amyloid imaging. It's not available here. So I'll restrict my talk here to the FTG imaging. patient should not only have memory impairment, but there should be a significant decline in cognitive function, which leads to interference in his day-to-day activity. Mere mild memory impairment does not qualify as dementia. So patient either has to generate an incoherent speech or should, be unable to identify objects or should forget his routine daily activities severe enough to affect his daily life. The utility of FTG PET-CT is maximum in cases with mild cognitive impairment due to Alzheimer's disease. In preclinical stages, of course, FTG PET can still demonstrate areas of hypometabolism, but it is unlikely that a patient with preclinical AD will present to you for imaging in the first place. And of course, when the patient has a frank blown dementia due to Alzheimer's disease, the decision is often clinical and psychometric. Very rarely will you need an FTG PET scan to diagnose. It's more often to validate the clinical diagnosis. Mild cognitive impairment, mind you, is a clinical diagnosis. It's not an imaging diagnosis. It is a clinical syndrome in which patient reports cognitive difficulties or even relatives bring it out sometimes, but they're not severe enough to affect the patient's day-to-day life. So these patients, the exact role of FTG PET in these cases is to differentiate which of these patients with clinically mild cognitive impairment eventually are going to land up into frank Alzheimer's disease, whereas the other group, based on the FTG pattern, will continue to stay as MCI and don't progress into Alzheimer's. So FTG PET-CT is likely if you see an area of hypometabolism in the parieto-temporal lobes and the entorhinal complex. These areas with the background of mild cognitive impairment are 18 times more likely to develop frank Alzheimer's disease on due follow-up compared to those patients with same clinical presentation but without abnormal brain PET. Hence, FTG brain PET has its highest utility in a suspected Alzheimer's disease who has clinically mild cognitive impairment to differentiate converters from non-converters. A case done a few years ago, mild hypometabolism. Clinically, patient had mild cognitive impairment. You have mild hypometabolism in the parieto-temporal lobes and the entorhinal complex. A follow-up done 2 years ago shows significant progression in the hypometabolism with dominant affection of the temporal lobes and eventually presenting as a frank Alzheimer's disease 4 years later. A classical textbook picture of parieto-temporal hypometabolism with significant hypometabolism involving the posterior cingulate as well as the precuneus. So this is a textbook picture of Alzheimer's disease. So bottom line, you can use FTG PET in a very early stage to differentiate clinically mild cognitive impairment who will progress to Alzheimer's versus who are just mild cognitive impairment because of non-pathological dementia. How good it is compared to the clinical evaluation. The sensitivity is obviously better with PET, and the specificity is also better. Most dementias have a lot of overlap features as far as clinical presentation concerns. Moderate to early advanced Alzheimer's patients also present with movement disorders, slowness in overall activity, and this may be misinterpreted as movement disorders but clinically, and hence an objective imaging with PET improves your clinical sensitivity as well as the specificity of labeling a certain type of dementia. Of course, we have amyloid imaging, which closely parallels the CSF beta activity, beta amyloid activity, but that at the moment is not available. And the next best available thing, FTG PET, which performs better than the MRI at the moment as far as the sensitivity goes, which is most widely available and used very commonly. Amyloid imaging, of course, wherever available, should be used not in all cases, but very classically in early onset of dementia, where you have a doubt if the patient has clinical Alzheimer's disease because of the atypical age of presentation, because these patients typically present with non-Alzheimer's dementias. You again have a great role in patients with mild cognitive impairment, especially if the patient is presenting with relatively younger age, say like 60s or 70s, because in older stages, you will have amyloid deposition also going up as a physiologic variant. And of course, if the dementia is of an uncertain cause and you want to assess or rule out Alzheimer's disease, you can very well use amyloid imaging for that. My take, however, on this, based on the literature that I have read, of course, I don't have practical experience in this, is in future, I think amyloid imaging would have a strong role in evaluation of ongoing treatment objectively or to test efficacy of ongoing drug, where actually giving a certain drug reverses the activity of beta amyloid deposition. So I think it is more useful for monitoring to ongoing therapy to an Alzheimer's disease, or perhaps testing the efficacy of drugs which can be used in cases of Alzheimer's disease rather than for diagnosing Alzheimer's disease. FDG PET currently available is fairly economical compared to amyloid imaging. It is more universally available. And in most cases, FDG PET, in addition to amyloid, will diagnose all other types of dementias as well. Hence, personally, I do advocate FDG PET over an amyloid unless there are a certain set of clinical indications, as I mentioned a while ago. I leave you with this thought at the end. Just like oncology, my oncologist had said that your prior imaging studies are your best friend. If you have a doubt, go back to the prior imaging, see how the patient has progressed or regressed. Whereas with neuroimaging, the clinical history is your best friend. Don't read scans in isolation. Go back to your data, go back to studies, and then based on that, you can essentially help you to narrow down with the diagnosis. In FTDs, patients typically present with early onset behavioral or speech changes, and focus of hypometabolism will be frontal and temporal lobes. With PSPs, patients present with typically with frequent falls, and areas of hypometabolism predominantly will be frontal lobes and the midbrain. With MSA, again, if it's cerebellar, you will have ataxia. If it's Parkinsonian syndrome, you will have MSA type P, and consequently the areas of hypometabolism seen here. Dementia presents with hallucination and sleep disorders, and you will have predominantly visual cortex hypometabolism. Whereas with CBD, you will have typical asymmetry in the scan reading with a clinical picture of asymmetric presentation as well as an alien limb syndrome. Thank you so much for the for the attention. This is palatial looking object as the hospital where I work at. That's my hospital, Saifee Hospital. Thank you so much. I'm open for questions.
Thank you very much, Dr. Parag, for an excellent talk, very practical points and tips. I'll open the podium for questions. I think that we have few questions in the chat
Yeah,
box.
there's one question in the chat box. For normalization, the brain scan, do you use the data created by you or use provided by the vendor? I use the standardized database provided by the vendor. A lot of vendors do not have the ability to create our own database. But most often, I think with brain, especially the variation, interperson variation across population globally should not be too different. So if I'm using what the industry has provided, as long as I'm sticking to the protocols that I acquire for the images, I think this data works just as well.
Great.
There's another question. Role of imaging in deep brain stimulation in Parkinson's disease. I think in DBS, the role of DOPA is primarily medico-legal. You have to demonstrate dopaminergic deficit before you actually take these patients for the procedure, because this is an invasive procedure. It's also a very expensive procedure, and you want to be doubly sure before you take this procedure for such an invasive procedure. I think the diagnosis is most often confirmed at that stage, and most cases that I see who come for DBS evaluation usually show a severe deficit in bilateral striatum.
All right. Dr. Parag, I have a question.
Sure.
You were doing the TRODAT scans and FDG brain. Every time I've attended some European conferences and I've attended those dementia sessions, usually they do a multiple set of imaging before they come to the diagnosis of dementia. Like even for any dementia, they start with the DAT scan. Here in US, we don't do that, right? We don't use DAT scan as our first imaging.
Right.
And
Right.
for Lewy body. So what is your clinical practice, and how do you manage these patients imaging wise? Like, let's suppose a patient comes with dementia. Do you look at if they have more movement disorders? You'll start with the DAT scan,
Yes.
or
Precisely. So very often the patient who present predominantly with motor symptoms, I first do a TRODAT scan, and once I have a TRODAT scan categorized as normal, then if there's an added component of dementia, I just have to see if there's Alzheimer's or not. Whereas if a patient is presenting primarily with dementia syndromes or a neurodegenerative process per se, I prefer to do the FDG PET as a first investigation. And if objectively demonstrates it gives me an answer, then I probably don't end up needing a DAT scan at all.
okay, thank you.
There's
Do
another there's another question here, role of PET-CT versus PET-MR for neurodegenerative disorders. Of course, PET-MR is going to be very good, but it is also going to be very, very expensive. Uh, Brain being a rigid organ, I think it is very easy to acquire an MRI separately and a brain PET separately, which more often is the case because by the time the patient comes for an evaluation with an FDG brain PET, patient most likely, most of them would have had a primary MRI done to rule out structural causes. And it's very easy to fuse co-resistor, the externally acquired MRI, with the FDG PET. So I would pretty much stick with FDG PET CT with a co-resisted MRI as far as neurodegenerative evaluation is concerned. In cases where you are looking for epilepsy, where the focal cortical dysplasias are really, really small and you have very, very tiny signal abnormalities, I think simultaneous acquisition in those conditions is going to be greatly helpful because you can simultaneously look side by side at the time of acquisition and consequently tailor your protocol to arrive to a more specific diagnosis. But for dementia imaging, I think PET-CT is just good.
Thank you. Do we have any questions? Otherwise, I can ask a question. Dr. Parag, you showed those fluorodopa images. Are
Yes.
you doing those in clinical practice and
Yes,
setting?
the cases from my practice, yeah.
Okay. So how do you decide whether to go for fluorodopa versus Trobrat? Is it on the patient's affordability or?
Yes, primarily yes. If there's a choice, I prefer to do fluorodopa as a first step. Uh, if fluorodopa isn't available as a second step, I do Trodat. Uh, Also, fluorodopa is available only once a week. Trodat is practically a kit available in-house. So if the patient is in rush, if this patient from outstation and they have an urgent appointment lined up, then I end up doing a Trodat scan. Otherwise, wherever possible, I prefer to do a fluorodopa imaging.
So what's the
There's another.
imaging protocol for fluorodopa?
So you typically preloading with carbidopa is optional. There is a literature which says it's helpful, but sometimes it's not helpful either. I initially started with preloading with carbidopa, but these days I just do it directly without preloading with carbidopa. I typically withhold this N-dopa for about 24 hours. The F-dopa injection is typically 5 millicuries, a wait time of about 60 to 90 minutes, and then a scan acquisition of about 8 minutes. That's a typical protocol. It's
Okay.
much shorter than the Trodat. It's quicker and it's far easier. The non-specific binding is lower. And of course, the image resolution with the DOPA is way better than the Trodat.
Thank you. Dr.
Uh,
Halkar has a
yeah,
question.
there's one more question. And what is the route of excretion of Trodat and biodistribution? Does renal function affect the scan of quality? No, the route of excretion is hepatobiliary. If you inject the Trodat upfront and you do a scan in first 15 to 20 minutes, you will see intense activity in the liver and gallbladder. And we remember doing a small little pilot study where we also started seeing heart like you see in MIBG patients. So that correlated with the extent of dopaminergic deficit. If you have a patient of dopaminergic deficit, you are less likely to see myocardial activity as well. So that's just a parallel to this. But yeah, renal function does not affect the quality of the scan.
Yeah, great talk, Dr. Parag. This is Amol. I have
Thank you so much.
a couple of questions about the
Sure.
role of imaging in Parkinson's and DBS.
Mm-hmm.
And in your experience, is there any data that shows that it works better for, say, pure Parkinson syndrome versus Parkinson plus and other syndromes to proceed with DBS, other than the medical legal?
No, not really. I don't think so. Basically, by the time the patient presents for a DBS procedure, it's a fairly advanced Parkinsonian syndrome, and based on the DAT scan or the F-DOPA, it's really hard to differentiate the two on the scan. One, the extent of dopaminergic deficit is essentially very severe bilaterally. So imaging-wise, there's not much to differentiate one of the two. FTG PET, of course, will be very helpful in these cases to further subcategorize. But by itself, that scan of fluorodopa is not very helpful.
Okay. And so do you do a fair number of FDGs in these patients as well, or?
Unless indicated. By default, I think it's largely demonstration of dopaminergic deficit. But if there's an additional component of a dementia, then yes, of course, we end up doing the FTG as well. But usually they're very well worked up clinical cases, and by the time they reach my department, they are usually labeled as Parkinson's syndromes.
Okay. And then, as you rightly pointed out, these patients tend to have a conundrum of findings, and it's not a pure disease, be it dementia or anything. And so a lot of times the scan patterns with FDG may have overlapping findings. And sometimes you don't know, especially if you're doing the software analysis that's vendor provided, you don't know which ones. Sometimes you have to let go of some findings, but others. So how do you deal with that variability in your scan interpretations?
I take help of the clinical picture here. I will sort of, it introduces some sort of bias in when I read the scan, but I look to it more as a support in reading scan diagnosis. Point one. And of course, the morphology definitely helps. If I'm seeing a random area of hypometabolism in a certain area which doesn't fit in with the clinical picture, and if I go back and see the CT part of it, I often find the atrophy out of proportion in that region compared to rest of the brain parenchyma. So then I correlate that isolated area of hypometabolism, which does not fit in with my pattern, to the atrophy and not to the disease pathology per se.
Okay. And then going back to your answer about the vendor provided database, what kind of scanner do you have, and do you correlate the acquisition of the vendor provided database to your scan acquisition? Because there's so much variability in the PET as well as spec world that we don't know how many data, that time of flight data versus non time of flight or G clear, and now there's digital PET and so on and so forth.
Yeah, so that's a variability, yes. I think I use Cortex ID. I think that has a good database. More important than what database we use, I think what is more important is one, your scan acquisition protocols should be ideal. Your dim lit room, the amount of dosage, the blood sugar levels, they have to be ideal. If they are not ideal, you're going to show up patchy random areas of hypometabolism on the statistically generated images. So I think even more than what database you use, this is more critical of how you generate your scans. I'm in the process of shifting from an analog PET to a digital PET. I don't have experience with digital PET compared to their normal database yet. Of course, I've asked the vendors to help me create a normal database wherein I plan to acquire brain extra images for whole body patients who have come who have a good preserved metabolism for the brain, and that will help me generate my own database. That's what I'm banking on.
Yeah, it should. In my past life, I had my own database, but the same thing happened. We changed scanners, and then we could not use that, and so we had to let go with the vendor provided one. So, and back to your question about PET-MR, although you don't do amyloid imaging, I think in amyloid imaging, where you're looking at the gray-white differentiation, the PET-MR may be crucial because we did amyloid imaging about almost 10, 12 years back. Unfortunately, at that time, because of reimbursement issues, we were not able to deploy it that well. But now, because there are treatments available for Alzheimer's, we're doing many more. But in the past decade, the scanner quality has improved significantly. And now we are picking up minute differences, and we don't know whether they're real or not. And lots of times, there is a discordance between the FDG PET and the amyloid, as well as the amyloid and the CSF tau. And so this is a very tricky situation, actually. So, I think that the PET-MR will be better suited to show you the gray-white differentiation. Unfortunately, I mean, we do have PET-MR at Emory, but it's so expensive that it's just not
precisely. Well, that's the whole point I was driving. I mean, nothing against MR. The whole point was it's going to be super expensive to do a PET MR, and brain being a rigid structure, it's very easy to acquire an MR separately and a PET separately and simply co-register them. So it's more economical that way.
Yeah, I mean, we had the same argument when PET CT came along, right? But so it does make a difference.
Of course. Eventually, yes.
Yeah. This is Raghu Halkar.
Yes, sir.
At Emory, in the last 30 years, initially we did a lot of neuroimaging. We did F-DOPA, we did dynamic F-DOPA, FDG for teasing out all the different kinds of Parkinsonian syndromes for a long time. but it all was as a research protocol. The moment the research money went down, the reimbursement shut us all down. So I'm just curious to know, these are paid, self-paid patients that you do?
Most of them, yes. Most of them are self-paid, yes.
Yeah. In Bombay, there are a lot of rich people there.
Yes, indeed. I mean, call it no alternative or rich, but they end up paying for themselves, yes.
Yeah.
Saifee Hospital on Necklace Road, Princess Drive. So,
Yes.
Yeah, even even in the US, there are a lot of rich people, but people would not pay if there is a third-party payer system.
True.
People will expect third party should pay, and if the third party doesn't pay, they think it is not worth it also, and they don't go for it.
Yeah.
But it's good that you guys are doing all this, and
yes,
the quality of your studies look pretty good.
Thank you.
Do you take an image of the injection site when you do TRODAT?
No, I do not. What I do is right after injection, I take, sorry?
Do you suspect sometimes the quality of image is poor or abnormal because of an infiltrated dose?
Yes, sometimes in retrospect, we do that. What I usually do with TRODAT is once I inject the product at about 15-20 minutes, I instantly take a neck and chest as a standard static. So that somewhat acts like a QC, because if I'm not seeing free pertechnetate in the neck thyroid and free pertech in the stomach, I know that the labeling quality is then very good, because ordinarily we don't do QCs for each radiopharmaceutical that's injected. So that's point one. And point two, if the scan quality, when we acquire about 4 hours later, if the scan quality is really poor, that can of course be because of bad clinical condition or situation of the patient, where patient indeed has true dopaminergic deficit that's severe enough. If the clinical picture doesn't match with the image quality, then we instantly take the injection site to see if there's significant extravasation. But ordinarily, as a routine protocol, no, I do not. Hello?
Hello. Good to hear that, because occasionally I also suspect when we do the DAT scan, when the quality is terrible, whether it is really the patient or the acquisition. And that 60-minute image of your, how often do you find motion artifacts, especially with Parkinson's disease?
Oh, very common. At least 1/4 of my patients I have to repeat the acquisition. The other option, of course, is to sedate the patient, but it may not always be practical to sedate so frequently. So we end up managing a decent study, but I do end up repeating a fair bit of patients.
So who does the QA/QC to determine if the patient needs repeat imaging? Because is the tech or somebody looking at in real time?
The tech looks into it, but I prefer to look at the scans myself before I start the. So the protocol at my place is, before the patient leaves the department, I have to see the scan, and once I say that okay, this is good to go, only then the patient leaves.
Okay. So you're basically holding the patient till you give the green light.
Yes.
Sorry.
And I'm glad to see that you showed a sinogram, which is a good tool to assess patient motion.
Yes, indeed. Yes.
But even at Emory, we rarely use sinogram for assessing the patient motion.
Right. It's helpful. I mean, when in doubt, it adds just a small bit of confidence to your overall degree of confidence to your overall understanding. So,
yeah, I think next time we invite you, we'll ask you to show some real scans and go over how you read them and scan interpretation, because that's another thing that I think our residents don't get good exposure to is how to actually read the scan hands-on, and that's what because with brain it's different, right? You're not looking at hotspots, you're actually looking at it, and it's hard to pick up negative defects. And plus, like the history is important, as you pointed out, with the overlapping patterns. So I think that's something that we're going to start, and I'm actually looking at a lot of people who do a lot of these brain imaging to come and give our residents to just show.
Very helpful. It's very helpful to give a more specific diagnosis.
Yeah, I should congratulate you for a good, excellent FDG PET CT quality of the brain. So I have a quick question.
Thank you so much.
What do you use a zoom And how many minutes is the acquisition?
So I typically use about
FDG?
8. Yeah, I
Pardon?
typically use about 8 millicuries of FDG dose. I do not use Zoom. It's a standard acquisition, and the acquisition is for about 10 minutes.
10 minutes. And your scanner, what sort of scanner do you
Currently, I use a Biograph Horizon, but I'm in the process of getting a new digital PET, which is the United Imaging UMI 780. So I'm expecting to get way better images than what I have right now.
Good.
But those are good images with United. We have a United in our system. For the brain, I don't think it made that much of a difference, actually. Just FYI.
They have their new recon algorithm called Hyper DPR. I don't know if you have that on your system, but if you do have an access to it, I think that improves.
We have that, and we're also helping them create another one called Hyper DLR, actually. So our is working with them to tweak the protocols and all that. But for some reason, because brain is a rigid organ and the counts are generally good, I didn't find that a difference.
I see. Okay. I mean, I'm not speaking for vendors, but I think generally vision gives the best images as far as brain is concerned. The Siemens Biograph Vision.
Yes. It is the Vision Siemens one is excellent images.
Yeah.
Just curious to know whether do you do any epilepsy focus detection?
Yes, few anecdotal cases, but not very routinely.
So you don't do SPECT and SysCom and all that?
Not SPECT we don't do, of course. I've done inter-ictal SPECT in my residency days, but from thereafter I haven't done ictal SPECTs at all. It's largely inter-ictal PET studies.
Okay. Go ahead, Dr. Halkar.
No, that was my last question. Thank you.
I just have one more point to make. I forgot to add it in the slides. F-DOPA versus TRODAT imaging. If there is a superiority of a particular modality over other, that's one more slide I wanted to add, but I forgot. So the literature says that theoretically, in early stages of Parkinsonian syndromes, the TRODAT is superior to F-DOPA because as the F-DOPA secretion goes, as the dopamine secretion goes down, the body tries to compensate by releasing more L-DOPA and reducing the amino acid decarboxylase activity in the body. So in early stages of Parkinson's disease, you actually may see a normal F-DOPA PET, whereas with a DAT imaging, you actually will start seeing dopamine transporter deficit right from the early stages. So there is theoretical superiority of TRODAT over an F-DOPA as far as the mechanism of uptake is concerned. There are 2 or 3 papers on this, but for all practical purposes, I think the higher quality of images that you end up getting with the fluorodopa and patients probably not presenting in as early stages compensates for this, and eventually F-DOPA ends up being a better modality than TRODAT. But I don't have any head-to-head experience per se.
The metabolic involvement of F-DOPA also adds some sort of wrinkles in quantitation. When we do quantitation, because there is a metabolic component, whereas TRODAT or DAT scan would not have a metabolic component of the radio tracer.
Correct. Right.
Well, excellent talk. Before Saima wraps up, I wanted to thank everybody, and I want to especially thank Dr. Halkar for promoting IASNM MSc talks in China. He's actually right now in China, and he actually invited the president of the Chinese.
Actually, the Chinese president-elect was logged in for a while, and I would ask him to attend these. They were interested to know the status of nuclear medicine in India, which is very good and very well. So I said this would be a good window for them to experience the developments of nuclear medicine in India.
So thanks to Dr. Halkar, IASNM's activities are getting noticed pretty well globally now, not just in India and US. So thanks, Dr. Halkar.
Parag, special thanks for the excellent talk.
Pleasure, ma'am. Pleasure, ma'am. Thank you so much.
Thank you.
All right. Thank you very much, Dr. Alan.
Yeah. Yes,
You should
Amol.
try to correlate with MISC if there is one.
Which one?
Molecular Imaging Society of China. Just like Missy, I think there should be an MISC as well, right?
No, there used to be one, but no more. There's one in Taiwan, actually.
Okay.
Yeah.
Excellent.
Yeah.
All right. Emma, you can wrap up. Thanks, everyone.
Thank you.
Thank
All right.
you.
Thank you very much. Thank you, Dr. Alan, for an excellent talk. And then
My pleasure.
And these talks will be available on our webinar series. So whoever can go in and download those. And we'll meet again, same time, same web space on May 4th. Dr. Prathush is going to be the next upcoming speaker, and you are all more than welcome. Thank you
so much.
Have a nice rest of the day.
Thank you.
Take care. Bye.